Good evening, everybody. I should be covering over the next 15 minutes or so about the emerging role of the new antifungals. We are now facing the invasion of the fungi. This study, which checked the incidence of severe sepsis from 1980 to 2000, revealed that there is a slight drop in the incidence of gram-negative bacteria. These statistics are from the United States of America. There is also a slight decline, even though the general trend is on the rise of gram-positive bacteria. But what is more disconcerting is the fact that there is a significant increase in the incidence of severe sepsis due to fungal infections. This is also associated with an increasing mortality, generally associated with Aspergillus and other mycosis. The incidence of Candida mortality is slightly low. And if you look at the people who are at risk of developing these fungal infections, you can divide it into two: the mold infections and the yeast infections. The molds generally are the Aspergillus, more commonly seen in heavily immunosuppressed patients, patients who are undergoing a hematopoietic stem cell transplant, people who have underlying malignancy who are subjected to strong chemotherapy. But the yeast infections are quite often seen by a lot of intensivists, people who are post-surgically in the ICU, people with concomitant lung disease, people who are otherwise ill, requiring ventilation, dialysis in the ICU on broad-spectrum antibiotics. These people generally are at increased risk, and we are finding more and more of these in India, probably because of the broader-spectrum antimicrobials we are using. What is also seen over the last few years is there is a general trend in the epidemiology which denotes a change from the typical infections which were more yeast in the past and Aspergillus, now towards probably an increasing incidence of zygomycetes. Whether this is related to the increasing use of voriconazole is still not clear, but this is definitely a trend which is seen. Another aspect which is now troubling is the occurrence of non-albicans species in Candida infections. Even though generally it has been perceived that Candida albicans is probably the one which is causing maximal problems, in India, and especially so over the last few years, we are finding an increasing incidence of non-albicans, mainly led by Candida tropicalis. This study done by Arunaloke Chakravarti showed that Candida pelliculosa, Candida guillermondi were also leading contributors in the overall incidence of Candida infections. Now, the significance of this is apparent when we understand that Candida albicans and probably tropicalis would respond very well to fluconazole. But when we are looking at other non-albican species, there is a concern that they may not respond to fluconazole, and we may have to resort to stronger agents like the echinocandins. And what is even more alarming is the fact that there is a slow but steady rise in the incidence of antifungal resistance. Earlier, albicans, which was generally almost completely sensitive to fluconazole, now we find an incidence of almost 7 to 10% of resistance for fluconazole and itraconazole to albicans. And the azole resistance was also seen in tropicalis. Keeping in mind the fact that most institutes in India report tropicalis as a major pathogen, and when we find that there is an increasing resistance, there is a worry that we may soon run out of fluconazole as an empiric choice in treatment of Candida infections. Another aspect to keep in mind is that fungal infections respond well only if the treatment is started early in the course of the illness. This wonderful study done by Gary et al. Who showed that the time to initiation of fluconazole therapy impacts mortality. So every day delay in the initiation of antifungals increases the mortality from 15% to as high as 40%. So we are finding an increasing incidence of fungal infections with increasing mortality, a shift in the epidemiology with rising resistance, and we have to tackle this fast. So what challenges do we face in managing invasive fungal infections? The first point is identifying the problem, that is getting the diagnosis right. In general, blood cultures pick up Candida only in 50% of situations. The next is whether we need to treat fungus or not. Very often we find multifocal colonization by Candida in a patient who is sick in the ICU. The question is, does it imply that the person is likely to develop candidemia? Because studies have shown that the greater the number of sites colonized by Candida, the more likely the patient is to develop candidemia. So do we go ahead with what is referred to as preemptive treatment, or do we wait to prove the infection? When do we time the treatment? If we wait too long, the patient may not respond well. So do you wait or do you start treatment early? What drug do you use? Because of the increasing resistance, Do we need to cover all patients with echinocandins with the fear that fluconazole may not work? And finally, the changing epidemiology. We have to think of unusual fungi even in our patients. Patients earlier who are not perceived to be to fall ill to aspergillosis, patients with chronic lung disease, patients with chronic liver disease. We are finding more incidences of aspergillus infections in these cases. The other factors which affect the selection of the antifungals would include the site of the infection, the patient characteristics, the potential for toxicity, concomitant use of other medications, available routes, and of course species and susceptibility of the infecting pathogen. Now, keeping all this in mind, we can very clearly one size doesn't fit all. So we need to move ahead to treat fungal infections appropriately. To understand a little bit more, this shows the fungal cell wall and the phospholipid layer. You can see the ergosterol, the beta-3 glucan synthase enzyme is at this. The phospholipid bilayer is seen here. The polyenes act at the level of the sterols. The azoles, typified by fluconazole, itraconazole, and voriconazole, all inhibit the CYP450 enzyme, which is responsible for the synthesis of ergosterol, and the newer echinocandins, like caspofungin, which inhibit the glucan synthase enzyme. So what choices are left to us? This spectrum of antifungals, which has been available since 1950, start with griseofulvin, then amphotericin B, and now we have a mushrooming of newer antifungals typified by newer azoles, voriconazole, posaconazole, isavuconazole, ravuconazole is in the pipeline, and of course the candins caspo, mica, and anidulafungin. So in a situation where we are treating serious fungal infections, which one wins? Is it the candins? Is it the azoles? To understand this, we need to again go into a little bit of the activity of the various agents. If you take amphotericin, which is clearly the gold standard till recently, considered the Brahmastra, associated with a significant incidence of nephrotoxicity which has been modified by the use of newer lipid formulations. It is available only as an IV preparation. The infusion-related toxicity can be minimized by giving steroids, and the nephrotoxicity can also be probably modified by giving it as an extended or a continuous infusion. Even though amphotericin B acts by a concentration-dependent fashion, giving it as an extended infusion, still the drug works and the toxicity is lessened. But we need to understand that there are several holes in the spectrum of amphotericin. Candida lusitanii, Trichosporon species, Pseudosporium, Pseudoalascheria boydii, and certain species of Aspergillus and other Candida like Guillermondi may not respond to amphotericin B. So it is very important that we know the speciation of the Candida, or even necessary the Aspergillus, before we can treat it appropriately. What about the azoles? Fluconazole lacks activity against Aspergillus, and we are also worried about the rising resistance to Candida. So is voriconazole superior? It's definitely superior because it has a wider spectrum. It takes care of Aspergillus also, but for Candida it offers very minimal advantage over fluconazole. And there are also significant drug interactions associated with voriconazole. If you look at the spectra of activity of all the available azoles, I have included the new azole posaconazole also. As you go down the ladder, you will find that the spectrum improves. Fluconazole acts only against Candida, certain species of Candida. Itraconazole has some activity against Aspergillus. Voriconazole is excellent against Aspergillus and several species of Candida. It doesn't work against the Zygomycetes, the mucor, whereas posaconazole, the newer agent which I shall discuss shortly, also works against mucor. What about the echinocandins? We are now having a choice of 3 drugs which we can use, caspo, mica, and anidulafungin. Technically, the maximum amount of information as far as the activity goes, we still have only with caspofungin, probably because it has been around much longer than the others. It is used, in general, the candins are advised in the management of severely ill patients suspected to have or suffering from invasive Candida infections. Caspofungin can also be used as an empiric therapy, whereas mica and anidula are not yet approved for empiric therapy. And there is evidence to say that caspofungin also works against Aspergillus, whereas the other 2 are still not approved in this indication. If you look at the susceptibilities also, against several species of Candida, both caspo and mica have very good activity, whereas for Aspergillus species, the information we have is only suggesting that caspo works against them, and there are few species which are covered by anidulafungin also. Now, are they effective for all our fungi? The CLSI has set breakpoints of less than 2 to indicate candida to be susceptible to echinocandins, and most isolates correspond to this level of less than 2, even though there is a slightly higher MICs for candida parasilosis for the echinocandins. In practice, it still responds to most of the echinocandins. If you take it a little further, dosing, Caspo is used in the dose of 70 milligrams as a loading dose and then 50 milligrams. Similarly, Anidula fungin also needs a loading dose followed by 100 milligrams for 50 milligrams a day. In the case of mica fungin, no loading dose is necessary, it's only 150 milligrams. Even though they are licensed for treatment of fungal infections in febrile neutropenic patients and invasive aspergillosis, I think currently in India we don't use this for these indications as much as we use it for candida. Mica fungin has an extra indication as prophylaxis for candida infection in hematopoietic stem cell transplant patients, where it is used in a dose of 50 milligrams once a day. What about special populations? The only azole indicated in neutropenic patients is caspofungin. None of the echinocandins require modification for renal failure. In hepatic impairment, Anidula fungin does not require modification, whereas both Caspo and Mica require modification, especially for moderate to severe failure. Only caspofungin is approved for use in pediatric, both Caspo and Mica are approved for use in pediatric age group, whereas Anidula is not. Drug interactions, the candins do have some interactions, especially caspofungin. It increases the area under the curve for caspofungin when cyclosporin is used along with it. Tacrolimus dose level is decreased by caspofungin. Nifedipine and sirolimus are affected by mica fungin, whereas drug interactions are minimally seen only with Anidula fungin. So after looking through the fungins, the candins, which would you claim as the winner? It is very difficult to say, even though all of them have minor advantages. It is claimed that Anidula fungin may work better in patients with liver insufficiency because dose modification is needed. Caspofungin works, the best information we have is with caspofungin. It is still very difficult to categorically say which one may be superior. What about the new kid in the block? Posaconazole. This has been very recently licensed in India. It is used as a prophylaxis for invasive fungal infections in patients receiving induction chemotherapy with AML or MDS. It's also used as prophylaxis in hematopoietic stem cell transplant patients. For treatment of fungal infections in adults, especially with aspergillus who are refractory to amphotericin B, or for fusariosis, it is advised. Posaconazole works very well against zygomycetes. It is the only azole which has activity against mucor. So it is very attractive when you need to give mucor, when you need to give treatment for mucor. You start off with amphotericin and then subsequently convert it to posaconazole because there are concerns about bioavailability of posaconazole. But the study which was done earlier, 4 or 5 years earlier, said that almost 60% of patients had either complete or partial remission of mucor with posaconazole. So this is a very attractive option, not only, as I said, for prophylaxis, but also in the treatment of mucor infections. The dosage of posaconazole for refractory invasive fungal infections would be 400 milligrams or 400 milligrams twice a day or 200 milligrams 4 times a day. For prophylaxis, it is used in the dose of 200 milligrams 3 times a day. It is available as a syrup, about 105 ml in a bottle. 1 ml contains about 40 milligrams. There are significant interactions with the azoles also. The maximum interactions are seen probably with voriconazole and fluconazole. Posaconazole has minimal interactions, mainly with cisapride. I'm sorry about the busy slide, but I think even I can't see from here. But just take it from me that unlike voriconazole and probably fluconazole, posaconazole has very minimal interactions. So we are in an era where we are having quite a lot of new antifungals. It is very difficult to place them because, as I said, even though Caspo has the maximum information available, it is difficult to categorically say it is superior to the other two, whereas similarly with azoles also, each has its own niche. I would like to leave you with this slide saying that even though we have come a long way in the treatment of fungal infections, I think we still have a long way to go before we delineate and probably provide the niche where the newer antifungals would fit in better. Thank you.